Good evening to all the doctors who have joined today and are still joining in large numbers for today's program. My name is Dr. Anup Hazare. I'm the medical lead for MCure Cardiovascular Division. I welcome you all for this scientific feast wherein we look forward to unveil the science behind the role of RAS blockers in the post MI space and how we have evolved over the years when we speak from the age old trials of SAVE trial of 1919 era to the recent post MI trial. I'm quickly sharing my screen here. So this is the agenda for the next 55 minutes, wherein a panel discussion is what we have requested the senior and eminent experts from our country who are the luminaries in the field of cardiology. And the topic today is RAS blockers in acute MI. From SAVE to Paradise MI, do we have a verdict? Please join me in welcoming our moderator for today's session, Professor Ranjan Kumar Sharma sir, who is a DM cardiologist. He is working as a senior interventional cardiologist and a senior consultant at Amri Group of Hospital, Manipal, Ruby General Hospital, and working in Kolkata. I welcome you, sir, and thanks for your time today.
Thank you.
We also have our experts who have joined in the panel. Dr. S.K. Agarwal, sir, who is from Kailash Hospital at Noida. Dr. Nitish Garg, sir, who is from Cardio Hospital from Jalandhar. Dr. Subhasish Mishra, sir, who is professor and heading the KIMS Hospital, KIMS Medical College and Hospital at Odisha. And last but not the least, from Hisar City, we have Dr. Abhishek Gupta, who is heading the cardiology department at Sarvesh Health City in Hisar. I welcome you all and thanks for providing us this opportunity on a Saturday evening. Just a word on the housekeeping. As a design of this meeting, all the participants will be on the mute mode. Therefore, if there are any queries or questions, I would request my participants to post it in the chat box so that our experts can answer to your queries during the panel discussion when the time is apt for taking up the panel questions. So with this, it's a pleasure for me to invite Professor Ranjan Kumar Sharma sir, and I hand over the session to sir for further moderation. Over to you, sir.
Thank you. Good evening. So we have a very interesting topic of RAS blockade because we have been using this RAS blocker for acute coronary syndromes for quite some time. And then we have newer molecules which have come, and what is the evidence and what we can learn from these trials. We'll be discussing on these things. Next slide, please. So an overview of RAS blockade in most device situations, we can use ACE inhibitor. That was the first molecule that was launched, and we have evidences from those trials by ACE inhibitors. We have ARBs, ARNI. Also, MRI is a RAS blocker, but it is not a substitute. So either or it's not that like that. It has to be given if it is indication is there or no contraindication is there. But we have an option of either of ACE inhibitor, ARB or ARNI. So we have to discuss which molecule for whether which one is better or in certain subset one can be better than other. Next. So for this ACE inhibitor trial, we have some selective group of trials where patients were selected based on features of heart failure, either clinical or by imaging, or in broad group of trials like Consensus 2, DC3 and ISIS4, where mainly patients of acute coronary syndrome, irrespective of the ejection fraction and heart failure status, the patients were given ACE inhibitors. And now let us see what is the evidence from these trials. Next. So this SAVE trial was done in late 1980s with captopril. And the target dose of this captopril was 50 milligram thrice daily. And the drug was started around 3 days to within 16 days after an onset of MI. And patients were selected based on LV ejection fraction less than 40%. And this ejection fraction was calculated by radionuclide scan because at that point of time that was most popular and considered better than echocardiography because echo was still evolving. And the trial was done for roughly 42 months. Thereafter, AR trial was done with ramipril with a target dose of 5 milligram twice daily. Again, the drug was started after 3 days of MI because in those days, once we started using ACE inhibitor, we had feared that patient can develop hypotension. So the drug was started quite long after development of MI. Although we know that the process of remodeling starts right after MI and the RAS activation happens just after onset of MI. But we started these trials after 3 days of MI. And these patients were mainly in AR trial based on either clinical evidence of heart failure in the form of RALS, LVS3, cardiomegaly, pulmonary, or patient had a radiological proof of pulmonary edema. And the trial was done for 15 months. And the TRACE trial thereafter was done with tenofovir, starting with dose of 1 milligram, gradually increased to 4 milligram. Again, started from 3 days to within 7 days of MI. And here echography was a parameter to be selected where ejection fraction was less than 35%. Next. So the idea from SAFE trial, what we got was use of captopril reduced mortality by 19% and reduction of recurrent MI by 25% by use of captopril with a dose of 50 milligram thrice daily. That was a target dose. And the process of remodeling was halted. So the further dilatation of LV was less in those patients who were given captopril compared to those who were on placebo. And this benefit was there whether patient was given thrombolytic therapy or patient were on beta blocker or not on beta blockers. And in those era, the primary angioplasties were not considered as a management for acute myocardial infarctions. So either thrombolized patients or non-thrombolized patients. Next. So in both the group, there was a benefit. This AR trial were much more sick patients who had a clinical features of heart failure. And ramipril showed there was a reduction of mortality by 27% and 19% reduction in the rate of MI and stroke at 6 months. And the dose of ramipril was 5 milligram twice daily as a target dose. Next. This AR trial was further analyzed after about 5 years. So those patients who were randomized to ramipril group or placebo group, and after the termination of the trial, those patients who were given ramipril and although stopped ramipril, the beneficial effect of RAS blocker in the early stage of MI in patients with heart failure, the benefit was sustained even after 3 to 4 years. So in the risk reduction, relative reduction in mortality was 36% and absolute risk reduction was 11%. So this trial shows that, this extension trial shows that if you halt the process of remodeling in the early stage of MI, the LV remodeling, if it is prevented in the early stage, you will have an incremental benefit or at least substantial benefit over the years. Next. And now TRACE trial was done where tenofovir 1 milligram was started and again increased to 4 milligram based on the blood pressure. And the trial was done for roughly 2 to 4 years. And it shows there was a 25% reduction in mortality, 15% reduction in recurrent MI, and 20% reduction in sudden cardiac death. So this trial showed a reduction of sudden cardiac death as well. That was generally seen with beta blockers only prior to that. Next. Then we had other trials where the patients were not very sick. It was a broad group of patients. Any ACS patients were prescribed in ISIS-4 study that was in 1995, then GC3 and CCS1 trial. And captopril was used in ISIS-4 study, and it was found to be effective in reduction of mortality within 5 weeks. We know that the maximum mortality of MI happens either before admission or within 1 day or by 1 month. So maximum mortality, if you see the mortality reduction at over 5 weeks, it means your drug has worked. And this advantage of survival was apparent even in the longer term. And GC3 trial was done with lisinopril, and that started 24 hours after MI. So it was the earlier use of ACE inhibitors, and it reduced mortality reduction, and also the LV dysfunction was less in patients who were prescribed lisinopril. And CCS trial was again, it was entry-level MI. So in ISIS-4 study, all acute coronary syndromes, and in CCS1, you have an entry-level MI. Captopril was found to be superior to placebo. You need to treat only 60 patients to prevent one death. Next. Now, based on these evidences from these ACE inhibitor trials, I would like to have some thoughts from our esteemed panelists. So whether you will use ACE inhibitor in this class of patients, like a patient, 75 years male patient, who is non-hypertensive and without any known coronary artery disease risk factors, he suffers from a small uncomplicated inferior MI. The LV size is normal and LV function is normal. Will you start ACE inhibitor in such a patient, irrespective whether revascularization has been done or not, to get any mortality benefit? So your thoughts on this. So we will invite some comments from our panelists. Or I will invite Dr. S.K. Agarwal to just have his view whether he will prescribe to this patient. Because so far the trials have shown only in patients who have LV dysfunction, the benefit is there. Yes.
Yeah. So thanks, Professor Ranjan, for inviting me. Basically, if you see the data, what you have presented from the non-selective, broad spectrum, huge patient population from the ISIS, the GC3 and CCS trials, enrolling almost 18,000 patients to 58,000 patients who were given early ACE inhibitors. And they all showed that there was a dramatic improvement with an NNT of 60 in CCS trial. But of course, this effect was diluted because of the unselected use of the ACE inhibitor in large population of myocardial infarction. On the other hand, if you see the initial trials, what you presented with the SAVE, ARRAY, and TRACE, those are the patients who had LV dysfunction or heart failure. So those are the trials where the use of ACE inhibitors were associated with a huge mortality benefit, ranging from 17% in SAVE trial to up to 37% in the ARRAY extension trial. So that is how like the thing is. If you see the latest guidelines also, they recommend that if you have entry-level MI, EF is less than 40%, you have heart failure, diabetes, or CKD. So these are the patients who are likely to get maximum benefit with the use of ACE inhibitors. Okay. So these are a subset of patients where it should be used and it is a class 1A indication. But in a non-selective population also, I will say that its use should not be limited, because ACE inhibitors are not only providing the benefit as far as the mortality is concerned, but they also have vascular effects. They also stabilize the plaque. They cause the reduction in the sudden death. They cause lesser rupture of the atherosclerotic plaque in the future, and of course the homogeneity is also reduced. And then of course there is a larger long-term benefit of prevention of remodeling. So, and of course the latest guidelines also put it into a class 2A recommendation that ACE inhibitor should be given to all patients with myocardial infarction, irrespective of the LV size and function. So that is what my call will be.
Yeah, that's right. Because we are, based on the earlier guidelines, most of the times we thought that only the heart failure patients should be given, but probably because of his anti-atherosclerotic. But this patient is 75 years, as a number of surviving years will not be that large. But if the patient is the next slide, please. So a similar profile, next slide, please. A similar profile if he's 45 years male patient. So our intention would be to give it more aggressively, because you will get anti-atherosclerotic property. So recurrent MI and progression of atheroma can be prevented. So in the earlier patient, yes, if you give or don't give, many of us may not criticize, but I will be very much keen to start in a younger patient because of his long-term anti-atherosclerotic property. Any other panelist will have a view on this. Next slide. Next slide. You can just go on to next slide. Yes. So this anti-atherosclerotic property of ACE inhibitor that Dr. Agarwal was saying, HOPE trial, SECURE trial, Europa trial, we have strong evidence that higher dose of ACE inhibitor, you have a higher benefit. And those who have no MI or just has got some risk factor, they have also benefited.
But at the same time, we should not forget, even in the IS and GC4, GC3 and ISS4 and CCS trials, we have seen that the mortality benefit is around 8 to 11%, even in the short duration, 5 to 6 weeks. So even in elderly population, I think we should be very open to use the ACE inhibitors in post-MI patients.
So in your view, it should be class 2A to 1. Anyway.
2A is also good, acceptable recommendations, I will say.
That's right.
No
Okay.
harm at least.
Yeah. Any other panelists want to say something on this?
Good. Yes, sir. Good evening, sir. So
Yes.
actually, sir, I do agree with you, Dr. Agrawal. Actually, the benefit of ACE inhibitor early in the stage of the acute MI, whether it is all evident that the most complicated MI like anterior MI do benefit greater than the inferior MI, uncomplicated MI. But there is a small amount of benefit still they will get from the inferior STEMI patient, because of this arthrogenic, anti-arthrogenic property and particularly prevention of sudden cardiac death. If the 75-year-old male and there is no contraindication to the ACE inhibitor and the ACE inhibitor is tolerating well in the 75-year male with in terms of the hypotension or renal dysfunction, I will prefer to continue it for at least 4 to 6 weeks. If the LV function is normal, I may discontinue the ACE inhibitor in that type of patient, in the older patient. But in the younger patient, I will like to continue the ACE inhibitor for a longer period because of the survival benefit, most important survival benefit. So I still prefer that small amount of benefit they'll get from the uncomplicated MI, even if the older age patients.
Okay. Thank you, sir. So we go to the next slide then. Next slide, please. Yes. Then ARB. So once the ACE inhibitor established their role in patients of LV dysfunction, we believe that ARB should be better than ACE inhibitor because we had the physiological reasons for thinking that ARB should be better than ACE inhibitor because the escape phenomena. So angiotensin 2 level can go up if the patients are given ACE inhibitor for a longer time. And the ARB working and by blocking the receptor final pathway, you will have more likely to have more benefit. That was our belief. And on this belief, these trials were conceptualized. This optimal trial and Valiant trial. Again, the patients had atrial MI or severe LV dysfunction with features of heart failure. And in optimal trial, losartan was used, and in Valiant trial, valsartan was used. And the mortality differences were not there. So ARBs were not found to be superior to ACE inhibitor. Next slide, please. So you see in this optimal trial, the losartan compared to captopril, there was practically no benefit. And the authors of this trial recommended that one should not go for ARBs because ACE inhibitor have been tested for a long time and it was cheaper at that point of time. And then next slide, next trial. This is a Valiant trial that showed again there is no benefit. But additional thing that it showed was this at that point of time we are thinking that more robust blockage of RAS blocker would have a better benefit. So in this trial we thought that ACE inhibitor ARB combination can be better. So in this there were 3 arms: captopril versus valsartan versus valsartan plus captopril. And the benefit with either valsartan or a combination over captopril was not found. And on top of that, the combination was found to be deleterious in terms of more risk of hyperkalemia, more risk of renal dysfunction and hypotension. So this trial proved that combination of ACE inhibitor and ARBs are not recommended, and the ARBs are not superior to ACE inhibitors. Next slide, please. So now many of our patients are on ARBs for control of hypertension, and because of, you say, more better compliance, because of less side effect of cough. And now a patient on, say, any of the ARBs suffers from acute MI, and now whether we'll like to switch from ARB to ACE inhibitor. Our other panelist, Dr. Garg.
Yeah.
Yeah.
This is Dr. Abhishek.
Yes. Yeah.
Good evening, everyone. So, what I found in our practice that we being most receiving the MI, many of the patients, they are already on some class of antihypertensive drug. But with regard to diabetes and hypertensive status, especially hypertensive status, we tend to change the drugs anyway. After the MI, the conditions change, the EF change. So we don't have any. I don't have any inhibition in changing the drugs from ARB to ACE inhibitor. There are side effects, or the patient already says that I'm having side effect with these drugs, then only I keep on with the ARBs. Otherwise, I stick to the guidelines and I change my drugs to ACE inhibitor. Yes.
Any other opinion from another person?
Yeah, Dr. Garg here. Sometimes we don't change, even if somebody is well stable antihypertensive ARB, and there is no problem with the previous anti-ARB. My voice is clear?
Yeah, clear.
Yeah. Sometimes we don't change it. If somebody is well stable blood pressure on ARB, so there is no hard and fast rule that you need to change to ACE inhibitors. There is no harm in continuing with it.
Yeah. Dr. Mishra.
Sir, can I say, sir?
Yeah, sure.
Yeah. So I would like to individualize the patient in this kind of patient. If the patient is really a prognostically bad patient, like anterior MI with signs of Kili class 3 and NYG classification is high and LV dysfunction is there, I would like to prefer to the ARB to the ACE inhibitor, ARB to the ACE inhibitor, because the quantum of benefit from the ACE inhibitor trial is substantial to the comparison to the ARB trial. If it is an uncomplicated uncomplicated MI, then I think we can continue with the ARB, because it is almost similar in some trial. But if the patient is really complicated MI, then it is better to switch to the ACE inhibitor from the ARB.
Yes, I will have just 2 points here. One, if the patient has got heart failure, then if ARB is valsartan or losartan, I will carry on, because we have evidence of this by these 2 molecules only. We don't have any. Most of our patients are either on telmisartan or even olmesartan. We don't have any evidence that these trials are useful for heart failure, although we believe they can be good. And secondly, the patients on ARBs, if you look at all the trials, although their outcomes are almost similar, but the MI risk is higher with ARBs. We have a pathobiological reason for that also. The ARBs causes decreased fibrinolysis because of the TP activity. The pi1 level goes up by use of ARB. So we have some subtle evidence that ARBs can increase MI. In a MI patient, if it is a high-risk patient, I will go from ARB to ACE inhibitor.
Yeah. So can I add something here?
Yeah, sure.
So basically, in my clinical practice, I am not a doctor who prefers ARB. So except for a few patients with hypertension, where I may use the ARB as a first drug, or maybe when the patient is intolerant to ACE inhibitor because of the cough, then I go for ARB. Otherwise, definitely I will like to switch over the patients from ARB to ACE inhibitor in a post-MI patient without doubt, because data is largely in favor of ACE inhibitors. So that is what my call is in my practice. But if you see the data, the 2 trials you have presented here, Optimal and Valiant, if you retrospectively analyze it properly, at least the trials have not shown that the ARBs were inferior to ACE inhibitors. So they were very well tolerated. Little bit trend was there in the favor of captopril over the losartan in the Optimal trial. but otherwise no difference was noted into the two trials. So ideally speaking, yes, ARBs are also recommended in the guidelines that only when the patient is intolerant to ACE inhibitor. Paradoxical MI is one issue which was raised in few of the trials, but I think subsequently in future trials it was negated that probably there is no increase in the risk of MI with the ARB use. But if you see the large evidence of data is in favor of ACE inhibitors, so definitely I would like to use this drug, ACE inhibitors in patients post myocardial infarction.
Okay. Next, we move on to the next slide. Next slide, please. Now coming to the ARNI. So this ARNI gave us a very robust benefit in patients of heart failure. And we know that your inhibition of neprilysin will cause increase in the ANP, BNP. And these molecules have a very good effects on vessels as well as myocardium and heart. So a person who suffers MI will have this ANP, BNP should be beneficial. So based on this Paradise MI trial was conceptualized. Next slide, please. So these patients had MI and this drug was started within 12 hours to 7 days of MI with ejection fraction less than 40% plus minus features of pulmonary congestion, with any of the risk factors like elderly person more than 70 years having atrial fibrillation, eGFR between 30 to 60, diabetic post-MI patient, or Kelig class 3, or STEMI without reperfusion. And the patients were randomized to ramipril 5 mg twice daily versus ARNI, and target dose was 200 mg twice daily. Primary endpoints were CV deaths, heart failure hospitalization, outpatient development of heart failure. And secondary endpoints were CV death and first heart failure hospitalization. Next slide, please. And this was this patients were recruited from all the continents, and a good number of patients were from India also. Next slide, please. And if you look at the inclusion criteria, they were almost similar in nature. So this this thing balanced patients on ramipril versus ARNI. Next. And it showed that the statistical significant benefit was not found in primary endpoints of CV death, first heart failure hospitalization, or outpatient heart failure development. There was a slight numerical advantage of ARNI over ramipril, but they were not found to be superior. Next. So this publication of Paradise, based on these primary outcome results, what are your advice or your opinion, please? Yes, any of the panelists, please.
Yeah. When I studied this trial, I think that in the very early stages of MI, the primary benefit of this ARNI and ACE inhibitors are on remodeling, and in such short period we can't say exactly that their effect would be visible in when we start this patient so early. So, but there is no harm in starting the ARNI in the early MI, that we can be certain of with this trial, though the benefit is not statistically significant. And if the patient might be likely to be continuing with the EF less than 40, and in future we have to switch the patient from ACE inhibitors to ARNI, then why not to start the ARNI in the first go, though from at a lower dose and then escalating it to the higher dose. So I think where the EF is less, then in my practice I start the ARNI at the lower dose and then escalate it to the higher dose if the patient tolerates it well.
You start in the very early stage ICU management.
Yeah.
Dr. Mishra, please.
Yes, sir. If you, sir, go into that trial, this is a superior trial. But had it been a non-inferior trial, almost ARNI is equivalent to the ACE inhibitor. But we need some more evidence to actually establish it. This is the single trial, and that trial event rate is very low. So basically, it is somewhat similar to the ACE inhibitor. But unless until we do have much more evidence, much more randomized double-blind controlled trial, RCT is there, meta-analysis is there. So at present, I think we better to go for AC inhibitor in a post-MI patient, starting from the day one, where the patient is actually the outcome is poor. And then we can switch over to the ARNI on a period that is when the patient is stabilized. Maybe that I don't know what is the time period actually when you have to switch over from the AC inhibitor to ARNI in a post-MI LV dysfunction patient. But I will prefer that after 4 to 6 weeks, I will change over to the ARNI if the LV dysfunction still persists. And we now evidence is that we can use the LVEF of less than 60% also ARNI. 40% is a very clear-cut guideline. But if the LV function dysfunction is there, LVEF still less than 40% after 4 to 6 weeks, I will switch over from AC inhibitor to the ARNI. But the immediate post-MI period, unless until we do have much more evidence, let us continue. We may continue AC inhibitor as usual.
Any other diverse opinion?
Yeah, actually, it was very unfortunate that Paradise MI trial failed. And in fact, if you see the two different opinions, there was 10% reduction in the primary composite endpoint versus 15%. But of course, even if we take the trial at per se what has been reported, one thing is sure that the ARNI was better, if not superior. It was better than the ACE inhibitor because it reduced non-significantly the primary composite endpoint. So that we have to accept this. Secondly, it was an event-driven trial. So 711 events were supposed to happen when the trial was supposed to be stopped. So obviously, when the 711 events happened, they stopped it and the result was what we had in front of us. Like our colleague was saying that after 1 month or so, we can switch over to ARNI. Probably I will not agree because that evidence is not there. And if you see the trial data from the SAE, Barre and others, what we have discussed till now, they were also carried on for around 15 months to 5 years in area extension. And they have shown a very remarkable improvement into the primary composite endpoint. Paradise MI was 23 months. So that was also a very long period. So median follow-up was 23 months in Paradise MI. So we did not have a superior outcome. So definitely in select population where the ACE inhibitors are not well tolerated because of the cough, somebody may like to switch over to ARB, but I will like to switch over to ARNI in that given situation, even in post-MI patients. Because we had such a wonderful result from the paradigm heart failure, reduction in the composite endpoint and mortality benefit, all-cause mortality benefit. But somehow we probably failed in showing this Paradise MI. Not only the ARNI, even the impact MI trial you talk about, the DEPA MI trial you talk about. So other drugs have also not shown a remarkable improvement in the primary commitment. So this remains a controversial issue. As of now, I will say that yes, I will start with the ACE inhibitors. I will continue the ACE inhibitors maybe indefinitely for 2 to 3 years in post-MI patient unless we have more data. Only in select patients where the ACE inhibitor is not tolerated, probably I will like to switch over to ARNI, not onto the ARB. One thing which I fail to understand, we all knew that the benefit of starting ACE inhibitor is when you start early, maybe in the first day. 40% reduction in the mortality is when you start on the first day. I don't know why the Paradise MI trial, the median start period of ARNI was 4.3 days. So did we miss a lot of patients where early initiation could have improved the outcome? That is one thing. Second thing is 1/4 of the patients in Paradise MI trial were non-ST elevation myocardial infarction. Of course, with LV dysfunction or heart failure. So whether that resulted into into somewhat lower event rate into the active drug group, I don't know about that. But yes, we will wait for some more trials to show that yes, it is good in the early phase of early myocardial infarction with LV dysfunction.
But in your last comment, there was just another data. This publication last month only, STEMI versus non-STEMI in the Paradise MI, the results were similar. So it was all were similar. Dr. Garg, any other your opinion?
Yeah. Basically, I would like to continue with ACE inhibitor initially, but if somebody is having good LV function, I would continue with ACE inhibitors. And if there is definite evidence of ischemic cardiomyopathy later part, then ARNI, I would like to switch over, because ARNI has robust data in severe LV dysfunction and moderate LV dysfunction. If there is mild or normal LV function, we would like to continue with ACE inhibitors.
Yes, yes, your last point was very good, because your LV function is very good. So we are now anti-atherosclerotic property of ACE inhibitor has been proven. So we have to give 10 milligram ramipril, that will, but ARNI, we have not shown any benefit in those type of trials. Yes. Next slide, please. So this trial, we are just skipping. Only benefit that was slightly more was in patients, the prevention of outpatient heart failure were slightly better with ARNI compared to ramipril. Next. This investigator reported again, it was a lesser outcome, outpatient heart failure thing was less. Next. And secondary endpoints, again, there was a numerical benefit was there with ARNI with compared to ramipril, but statistical significance was not there. Next. So we have the adverse effect. We, as you all know, hypotension was more common in patients with ARNI, and cough was more prevalent in patients who were on ramipril. So that was the reason for discontinuation also. More number of ARNI discontinued because of hypotension, and more number of discontinuation because of cough with ACE inhibitor. That is known to us. And you see this, but there was a divergence of curve after about 6 months. So you have some benefit, probably longer duration trial, or maybe more sick patient would have shown better benefit. We are not sure. Next slide, please. So this is the slide that I was saying, that compared to ramipril, this ARNI did not significantly decrease the risk of CV death, heart failure in patients with MI complicated by LV dysfunction, irrespective of type of MI, whether non-STMI or STMI. The outcome were similar. So it's not that STMI would be better with ARNI. Yes. Next slide, please. So to summarize, sacubitril valsartan did not result in significantly lower rate of CV death, heart failure hospitalization, or outpatient need for heart failure treatment. Pre-specified observation of reduction in both investigator reports of primary composite as well as in total recurrent adjudicated events to support incremental clinical benefits of ARNI. The safety and tolerability of ARNI in this MI patients was comparable to that of ACE inhibitor. So we can use this drug. And just because of the huge benefit that we got with in the paradigm heart failure trial, we had a huge hope that there will be benefit. So there were a number of papers in various scientific journals that the authors were surprised that this ARNI is not superior to ramipril. So what is the reason? Can you have some reason for this outcomes were not better? Because in paradigm heart failure, there was a benefit, and in this Paradise MI patients, there was no benefit. Yes, Dr. Agarwal, please.
So I think we have already discussed about that. Maybe in my opinion, could be a little late initiation of drug at a mean of 4.3 days.
But was it different from ramipril group also? Ramipril started earlier or ARNI was started late?
No. My point is that 40% reduction in the mortality if you initiate ACE inhibitor on the first day after. So if you start late, probably the dilution effect may be there. So that could be one thought process. Second is, of course, you are comparing the drug with the best possible ACE inhibitors. So that is one thing. So probably you need a longer follow-up to have a meaningful impact, of course. So that could be one. Second thing. And otherwise, I think it's a good drug. We will have to wait for some more trials and data.
Yes. Any other panelist, any opinion on this? We don't have any clear-cut answer why it didn't show any benefit. Although with the ACLE2 inhibitor, again, the same thing has been shown. Yes, Dr. Garg, please. Yes, you want to say something?
No, same from my side also. Because it is very difficult to say why ARNI was not able to do in primary endpoint. But still, bradykinin could be one of the things which is not with the ARNI in comparison to ACE inhibitors. where
Yes.
we have a definite vasodilatory effect of ARNI, which is not a vasodilatory effect of ACE inhibitors, which is not with ARNI. So this could be another explanation which we can just postulate.
Yes. Next slide, please. So we just give some scenario where which RAS blockade you will give. A patient of interval MI at 1 month comes to you with ejection fraction of 40% and no symptoms of heart failure, not on any RAS blockers. Whether you will give ACE inhibitor, ARNI, or ARB, or you will not give any. So probably none is probably it's ruled out by everyone.
Yes, agreed. ARB is also ruled out
Ruled out.
for me.
ACE inhibitor or ARNI. Your first choice would be?
Probably I will go with the ACE inhibitors.
Yes,
Because it's a post-MI patient, so I will go with the ACE inhibitors.
Dr. Garg, again, everyone is in the same line or?
Yeah, basically ACE inhibitors, again, I would say because LV ejection fraction is 40% or more. So in those cases, I would prefer ACE inhibitors in comparison to ARNI. If they have written ejection fraction 35% or 30%, I would have gone for ARNI because then severe LV dysfunction, you should prefer ARNI in comparison to ACE.
Asymptomatic patient also, yes.
Yeah.
Next slide, please. Now this patient, same ejection fraction, same time, but he has got class 3 symptoms of heart failure. So now Dr. Misra.
Yes, sir, because this is a class 3 symptoms of heart failure. And we know that in heart failure study, the ARNI has a better outcome from the ACE inhibitor. So I think only the query is that post AMI 1 month period. Symptomatic patient, I will prefer ARNI if the period is 1 month, grace period of 1 month after post-interval MI. But there is no clear-cut guidelines. We'll prefer either ACE inhibitor or ARNI. But because it is symptomatic, class 3 symptomatic, I'll prefer more ARNI over ACE inhibitor.
Yes. So.
Basically, I would just need to add certain things because if somebody is having 40% in class 3 symptoms, it is not matching. Either somebody is having regurgitant lesion or he has significant stenotic lesion in the coronaries. So we need to evaluate on those lines before labeling that this class 3 symptom is because of ejection fraction. So you need to concentrate on these lines also.
Yeah. That will be true, Dr. Nitish, but why can't it be? Class 3 symptoms with even ejection fraction of 55% you can have in the heart failure.
So then diastolic heart failure should be considered, and then these things are not in. Then ARNI is not in a choice.
My question is, NYHA class with ejection fraction, there is no need to be association or dissociation needs to be there.
Then you need to look for other things also. Because class 3 with 40% diastolic failure could be considered, but ARNI is not helpful in diastolic failures.
In any case, with this patient, just 1 month class 3 post-interval infarction, so I will still prefer to go with the ACE inhibitor because in 1 month...
You would not like to evaluate coronary artery disease or
myocarditis? Definitely, that has to be done. That has to be done. That's not a question.
That should be the primary, rather than just blindly continuing with the medication.
Your point is taken. Yes, you have to look for a complicated
MI. Patient has MI, patient has LV dysfunction, so coronary artery disease evaluation and all those work has to be done, no doubt about that.
Next slide, please. Now a patient was on ACE inhibitor, and at 1 year you have found that the ejection fraction has dropped to 35% and has now progressively worsening of heart failure. So everyone will agree we'll now switch from ACE inhibitor to ARNI.
Yes, agreed.
So everyone will be switching over.
Definitely, yes.
Of course.
Next slide. Now another scenario, interval MI, post-PTCA patient, day 15, ejection fraction 35%, grade 2 MR, systolic blood pressure of 110. He is ACE intolerant because of cough and having class 3 symptoms of heart failure. Your concern is low BP. Will you start with ARBC with valsartan first and then switch to ARNI because valsartan is less likely to be causing hypotension compared to ARNI? Or you will go with half dose of ARNI to say half tablet of 50 milligram twice daily? Dr. Abhishek has not given his thoughts for a long time. Abhishek is there?
Yeah.
Yeah.
Yes, sir. Actually, again, ARNI, they do have hypotension, and but I still think that if the EF is less and there's already patient is intolerant of ACE inhibitor, and even if the patient is tolerating ACE inhibitor, then we have all seen the benefits of ARNI on the functional class, and that we have done practical and as well as also on EF. So I would start with the very minimal dose of ARNI, and with more frequent follow-ups, I would be increasing into the maximal tolerated doses.
Yes, Dr. Garg, please.
Yeah, I would definitely agree with Dr. Abhishek, because we have seen that with 110 systolic blood pressure, ARNI is quite well controlled. And symptomatic benefit is a lot. Even if the blood pressure is 110, 100, and even 90, even if it drops to 90, even then we like to continue with ARNI rather than not getting the benefit of ARNI. So definitely ARNI should be the choice. Initially low dose, and we need to see concentrate on diuretics, nitrates, or any other antihypertensive, which is stopping us to increase the dose of ARNI.
So here I will just beg to differ a little bit, because when we are switching from ACE inhibitor to ARNI, we have to stop the ACE inhibitor for 36 hours for washout period. So that 36 hours will be very crucial period for this patient who is just 15 days symptomatic with ejection fraction 35%, and he is having a borderline pressure. So definitely in this patient, I will stop the ACE inhibitor. I will start the ARB. I will continue it for next 36 hours or 48 hours, whatever is required. And then maybe I will switch over to ARNI, but I will not switch over to ARNI directly from ACE inhibitor to ARNI.
Yes, I put this question because I have seen none of the cardiologists are practicing in that way. I have just once a hypotension is there, I started with the valsartan, very small dose, 40 milligram twice daily for 2 to 3 days, and then switch over to ARNI. Because it becomes much safer, because in a very sick patient, blood pressure is low, you never know how the patient's blood pressure will behave. So, but anyway, some can give very small dose, 1/4 of tablet of ARNI. But I believe valsartan then, because it's the same molecule, and you can switch over ARNI very easily.
Yes. And that holds true even for chronic heart failure also. When the patient has a borderline pressure and you want to start the ARNI, and probably you find that it may be difficult. So it's always a good idea to start with the valsartan initially at a lower dose, up titrate it a little bit, and once you feel that patient is maintaining the blood pressure at a reasonable level, then you can switch over to ARNI and stop the valsartan.
Yeah. Next slide, please. So this is a very clear-cut remote MI untreated patients. This is not very uncommon in India. Patient comes in class 3 heart failure. Here only ARNI. There is no choice of any other aspect. Next slide, please. So what is the current guidelines? So the guidelines suggest the CSC guidelines 2020 for acute coronary syndrome with non-STMI. That Dr. Agarwal was saying in the beginning, that ACE inhibitor, if not tolerated, then to ARB. In patients who have heart failure with reduced ejection fraction, with diabetes or CKD, unless contraindicated by hyperkalemia or renal dysfunction, and it will reduce cardiovascular mortality and cardiovascular morbidity. And the indication, the class of indication is 1, and level of evidence is A. Next. This is the latest guideline of acute coronary syndrome, RAS blocker. ACE inhibitor, again, class 1 with ejection fraction less than 40%. And this routine ACE inhibitor for all ACS patients, regardless of LV ejection fraction, should be considered as a class 2A indication. Next slide, please. So any other your thoughts whether the guidelines should name this ARNI molecule as a RAS blocker in our future guideline? Dr. Misra, please.
Yes, sir. Like we have already discussed this thing that we need some substantial evidence, a robust data to actually change the guideline. So only the Paradise MI is the only single trial which has shown some similar benefit with ARNI and AC inhibitor. But
I just interrupting you just one point, because they have said that patients is getting cough, you switch over to ARB. So whether the newer guidelines would say that you can switch over to ARB oblique ARNI?
Yes, sir, might be, because it has been all the trials shows that the cough is not actually an issue for the ARNI, and the AC inhibitor AC inhibitor induced cough, there is less chances of the in the ARNI. So with a similar data, similar efficacy, only the indications may be the patient who is not tolerating the AC inhibitor.
Yeah.
So that there may be a ARB or ARNI, and ARNI is the superior choice over ARB.
Yes. So the guidelines should not change till we have some more evidence. Dr. Abhishek, you want to add something?
No, sir. I'm in sync with your thoughts that ARNI, yes, there are only limited data, but because when we have to switch, we can switch to ARNI. Yes, there is a washout period that is mentioned, but in my opinion, that washout period is there because of the effect of ACE inhibitor stays and for some time, and then we can switch over to ARNI. So, but we need more trials and even larger studies, because the events rate, they can be compared only when there would be larger studies. So perhaps in near future, the guidelines might see a change.
Okay, next slide, please. So if you are starting ACE inhibitor or to a patient, what level of blood pressure, systolic blood pressure you will start ACE inhibitor? What will be the starting dose of your ACE inhibitor? And how do you up titrate? Dr. Abhishek, please. At what level of systolic blood pressure you will start ACE inhibitor in post-MI?
Yeah, again, in more than systolic BP of 90 or 100, even more than 90, I would start ACE inhibitor at a very minimalistic dose. And in that patients, I would call the patient early and see for the hypotensive effects, symptomatic as well as at the actual absolute BP levels. And then I go very slowly. And with time, the patient tends to tolerate both symptomatically and as well as BP levels also, they get maintained. So then every 1 or 2 weeks or 2 to 4 weeks, we tend to increase the ACE inhibitor level.
Dr. Misra, your level of blood pressure, you choose at what level? Dr. Misra?
Yes, sir. Sir, I will prefer the systolic blood pressure if it is above 90 to 100, mostly more than 100, because AC inhibitor is shown to be has this effect, hypotensive, more hypotensive effect than the ARNI. So I think 100 should be the cutoff for the AC inhibitor. Apart from hypotension, I also have to look about the renal function, particularly hyperkalemia, because most of patient of the post-MI LV dysfunction, we tend to add mineral corticoid MRA, and MRA with a AC inhibitor, that the potassium level we should check it very regularly, and that may be the one of the reasons why we'll have to either have to stop mineral MRA or we have to down titrate the AC inhibitor. So blood pressure wise, I'll prefer 100 millimeter of mercury should be the cutoff, and we have to check it regularly for the hypotension and the renal dysfunction and the electrolyte imbalance.
Dr. Agarwal, please.
At what systolic blood pressure do you initiate? So I do not initiate until unless at least the systolic pressure is 110 millimeter mercury. So if it is below 110, I will be very, very skeptical to start the ACE inhibitor. starting dose is I start with the short acting, smallest possible dose. So maybe the captopril 6.25 milligram 3 times a day, and I up titrate very fast. So first dose hypotension is not there, 6.25 milligram I have given. Next dose will be 12.5 milligram in the morning. And if it tolerates 12.5 milligram BID or TID, then I will switch over to maybe the ramipril immediately, very next day. So up titration is fast. At least I would like to have 5 milligram of ramipril the patient should be on before discharge. So that is how. And as the patient condition improves, subsequently I decrease the dose of the loop diuretics, IV diuretics to oral, and maybe the minimum possible dose, and then I go up with the ACE inhibitor. That is what the protocol is normally in my practice.
Abhishek? Yes.
Yeah. Can I add few things? Basically, only the number of blood pressure measurement should not be the criteria. Definitely, I would like to start, first of all, if 100 or above the blood pressure is there. But we need to watch few things. One is symptoms of hypotension, like postural hypotension, easy fatigue, urine output, renal function. All these should be considered, not only the number of that the blood pressure, systolic blood pressure. Even if we have seen the patients who are 90 or 100, even 80, sometimes the symptoms of the patient is very much improved. So if somebody is well tolerating higher doses with low blood pressure levels, there is no harm in continuing or increasing the dose. But even if somebody is having 100 systolic blood pressure, renal dysfunction, hyperkalemia, postural hypotension, then you need to reduce or stop the dose. So that is another thing which we need to see.
So next slide, please. So we are almost nearing the end. Next. So you believe that the ACE inhibitor, all the ACE inhibitors are similar, or we have some different ACE inhibitor behave differently? Next slide, please. So ramipril over other ACE inhibitors post-MI, we have some data. There was a publication by Pilot in 2004. He analyzed 7,000 plus patients of acute MI, 30 days after MI, post-discharge and up to 1 year. Patients were given either enalapril or lisinopril, fosinopril. At that point of time, these drugs were used. Ramipril 12%, captopril 6%, quinapril even, or perindopril. And they observed reduction in mortality with different ACE inhibitors. Next slide, please. Now you see that the survival at 12 months was maximum with ramipril. Roughly 90% patients survived. And you see the captopril had the lowest survival, that is 77%. So the survival curve you see on the right-hand side, the over the months, you have a decreased rate of death in patients who are on ramipril compared to all other ACE inhibitors. So we believe that all ACE inhibitors are roughly similar, all will give benefit, but ramipril scores over other ACE inhibitors. That is data from this, and this MITRA plus another trial was, this meta-analysis was done that showed the same thing. So we believe that, and probably all of us now we're giving ramipril rather than any other pills. And Dr. Agrawal was saying about captopril in a very hypotensive patients, we can start with 1/4 of the tablet and a very short-acting drug. In those situations, we can still give captopril for say 21st 48 hours, then we can switch over to ramipril. Do you believe that ADHF after MI within days to weeks is a different syndrome than those ADHF in MI after months to years? So do you believe there are two different types of syndromes? Dr. Misra?
Yes, sir, maybe that is pathophysiology-wise, if a recent MI ADHF, there may be multiple mechanisms behind it, like one of the mechanism, other than the LV remodeling part, there may be vascular part, the microcirculatory dysfunction, or there is a neurohormonal pathogenesis or cardiorenal syndrome. They play all the mechanisms in a post-MI, recent MI ADHF. While a remodeling actually has an effect on the LV dilatations with structural heart disease like secondary mitral regurgitations and the comorbidity factors. They play a more important role after ADHF in a MI after months to year, which we can be termed as a ischemic cardiomyopathy. And treatment-wise, right now we have evidence that ARNI is still. We are skeptical about use of the ARNI in a very early MI, ADHF or LV dysfunction. So treatment-wise, in a recent MI, ADHF, we have to be managed differently other than the ischemic cardiomyopathy.
It's 9 o'clock.
And the treatment may be more towards the SE inhibitor rather than the ARNI. But after a AMI, after months to years, all the guideline-directed medical therapy for a heart failure or the LV dysfunction should be targeted. So there is some treatment difference between the recent MI, ADHF and the ischemic cardiomyopathy.
So we have just almost over, time is over. So we switch over to the next question. Yes. Do you believe asymptomatic LV dysfunction after MI should be treated differently from symptomatic patients? As far as RAS blockers are concerned, Dr. Agarwal, your last point and last comment here, because we are short of time.
Okay, so as far as the RAS blockers are concerned, I think symptoms or no symptoms, it doesn't make much of difference. If LV dysfunction is there, I think we should go with the guidelines, class 1A recommendation, and the RAS blockers should be given.
Yeah. Okay, so next slide, last slide, yes. Next. So take-home message, in post-MI patients with LV dysfunction, ACE inhibitor consistently shows the reduction of CV deaths and all-cause mortality in various trials. ACE inhibitors seem to have a class effect. However, there is a data to suggest that renipril will be more better than other ACE inhibitors. Cardace MI is the first and only clinical trial of sacubitril valsartan, but did not outperform renipril in acute MI population. An renipril dose of 10 mg per day is a dose which offers maximum benefits, proven by this AIR study and Cardace MI. Thank you. So we had a wonderful discussion, and at the end of all, even if this subject is old, we continue to learn every day from each of us.
Yes, truly.
Definitely.
Yes.
Thank you, sir. I thank all the experts for providing us this opportunity and giving their valuable time on a Saturday evening. And take this opportunity to thank our audiences. Also hope they have gained a lot of insights from this discussion on the role of RAS blockade in the post-MI space. So thank you, everyone.
Any questions from the audience side?
Yeah.
So there are couple of questions, sir. If you allow me, we can take them, sir.
Yeah.
I think that should be honored here.
Yeah, definitely.
Yeah. So there was a question which I got privately, sir. Do you advise for giving beta blocker in combination with ACE inhibitors while discharging the patient?
Yes.
Sir?
Yes, actually I don't combine. I give a beta blocker in the morning and ACE inhibitor in the night, because blood pressure effect would be, and the anti-renin pathway would be blocked in 24 hours a day. I generally don't combine. You can have some different opinion.
No, that's very true.
Basically, we need to give both the agents.
Yeah,
Whether you in a combination form or not, that's a different issue. But both the agents should be given to post-MI patient, beta blocker as well as the ACE inhibitors. So basically, the question is, I feel so. It is not basically the combining the medication. It is basically both the things should be prescribed.
And how long do you think beta blockers has to be given, sir?
Lifelong. Ischemic heart disease, lifelong.
Lifelong it has to be.
Again, I will slightly beg to differ here. So, post-MI patient with LV dysfunction, yes, beta blockers, class 1 indication to be lifelong. Post-MI patients with normal ejection fraction, nowadays there is hardly any recommendations to continue it further.
Yeah.
So, if the LV function is 50% or above, even the post-MI patients, the data is insufficient to support that it should be continued. Yeah, both the medicines can be initiated in the patient in the acute phase after myocardial infarction. Then later on, depending upon the ejection fraction, you can take a call. Or if the patient has arrhythmic episodes or some other indication for the use of beta blocker despite having a normal LV function, then it's okay. Otherwise, in a normal LVEF patient with post-MI, I will discontinue the beta blockers.
I do use, but I don't teach. I teach that you should stop because we don't have any evidence now.
Yeah.
But I do use.
Okay, sir. 45-year-old diabetic patient and having a microalbuminuria. So would you recommend ACE inhibitor or ARB for this subset?
Again, if you look at the trials of renal disease and ACE inhibitor ARBs, for type 1 diabetes, we have more evidence with ACE inhibitor. For type 2, we have more evidence with ARBs. So, renal disease, I will prefer ARBs in type 2 diabetes.
Okay, sir.
So IDNT, renal, and so many others. So obviously, but in non-diabetic patient with albuminuria, the next question. Because I think he did not ask for the 45-year male albuminuria, he said, but he did not mention whether he is diabetic or non-diabetic.
So any RAS blocker plus SGLT2 inhibitors.
Yes.
Yes, SGLT2 inhibitors will have a precedence over the SGLT2.
Yeah.
There is one question that, sir, there are little evidences that, combining calcium channel blocker with ACE inhibitor can reduce the incidence of cough. What about your view? Okay. No idea.
Anyone?
I think, no, there is a probability that if you have peripheral edema with the calcium channel blockers, then if you combine with the ACE inhibitor, the edema subsides. So that's a different scenario. But I think maybe the question who have asked got little confused. So not on the relation to cough, it is basically in relation to peripheral edema.
Edema. Okay.
So, yeah.
Right, sir. These were the questions in the chat, sir. I think with this we can conclude, sir. Sharma, sir, with your permission.
Sure. Thank you.
Thank you so much, sir.
It was really an enlightening session and we all learned a lot. So thank you very much, Professor Ranjan, and all my colleague friends. Good night, everybody.
Good night. Good night.
Sir.
Good night, Nilesh. Bye-bye.
Bye-bye.
Thank you so much.
Recording stopped.